Hi class! In this lecture, I will review antidepressants. The objectives are listed on the slide. They're also listed in Blackboard under the antidepressants module. There are some vocabulary words. Please review these and be familiar with the terms. Okay, let's get started. So in the United States, about 30% of patients experience some form of depression during their lives. It's also known that at any given time, 1 in 8 adults is depressed. Sadly, only about 50% of these folks seek help, and only 20% of those are going to receive adequate treatment. The good thing about the drugs that we use to treat depression is that about 30% of the time, if the drugs are given at appropriate doses, the patients can achieve full remission. About another 30% of the time, the patients will experience at least a 50% reduction in symptom severity, which isn't so bad. I think the main thing here is that not all patients seek help. They feel embarrassed about depression. They just don't kind of put themselves out there to get the help that they need, even though there are some good treatment options. But major depression is the most common psychiatric disorder that we'll see. It is more frequently in females as compared to males. And one of the most concerning things about depression is that the suicide risk is pretty high among these patients. And I already mentioned it's underdiagnosed largely because patients don't seek therapy and also because of that undertreated. Even in those patients that do seek therapy, in many cases the treatment's not adequate for a variety of reasons, which we'll talk about. So clinical features, I guess first and foremost, major depression is different from grief or sadness. So grief or sadness is an appropriate reaction to some type of life event, such as the death of a loved one. Generally, this grief or sadness will resolve spontaneously, and it doesn't last that long, usually a couple weeks or maybe slightly longer. Depending on what the life event was that occurred. Now, there could potentially be a major depression superimposed on top of grief, but that's really kind of the difference between your grief and sadness, kind of this appropriate reaction that eventually resolves, versus depression, which is not triggered necessarily by a particular event. In terms of the diagnosis, there are guidelines for diagnosing depression. So your symptoms must include either a depressed mood or anhedonia, which is inability to experience pleasure. The symptoms have to be present most of the day, nearly every day, for at least 2 weeks. And there can be also other symptoms that go along with the depressed mood or anhedonia. So things like insomnia, anorexia or weight loss, kind of concentration or mental slowing, feeling guilty or worthless or helpless, and then of course thoughts of death or even overt suicidal behavior.
So let's briefly review the pathophysiology of depression. So the underlying cause of major depression is unknown, but it's probably multifactorial. Multiple theories exist, but there's no single unifying theory that's agreed upon in the medical community. But as I said, multiple theories exist, and most of the theories will state that the development of depression involves a complex interaction likely related to genetic predisposition, physiologic stressors, as well as the underlying pathophysiology that's occurring in the patient in the brain. So with regards to genetics, it's known that first-degree relatives of patients with major depression are about 3 times more likely to develop major depression. Twin studies and adoptive studies have also suggested that there's a genetic influence. There are some genes that have been identified that are related to depression, but there's a lot of ongoing research. In terms of the psychological stressors, a variety of major life stressors can occur that certainly don't always cause depression, but there certainly is an undeniable association between life stressors in general and depression, and there seems to be a causative interaction, especially with regards to stressors and genetic predispositions. So we know these factors are involved. We just don't know kind of the exactly how and what the exact makeup is. Additionally, there is definitely uh, a relation to a change in the brain neurotransmitters, specifically norepinephrine, dopamine, and serotonin. And I have those abbreviated on the slide. Dopamine is DA, norepi is NE, and 5-HT is serotonin. Now, again, there's not necessarily one explanation. There are multiple theories, but kind of some of the prominent theories are that there's a deficit of these chemicals, that's the monoamine deficiency theory, or there is some type of receptor dysregulation with regards to these neurotransmitters activating receptors. I think that's about all I want to say about the pathophysiology. I think in general, from a pharmacologic perspective, it's helpful to consider the underlying pathophysiology because all of the drugs that are used are going to ultimately influence the amount of dopamine, norepinephrine, and serotonin. So all of these drugs are going to increase the amounts of these neurotransmitters.
So let's talk about the pharmacology of the different drug classes that we use.
So there are 5 prescription drug classes that are the most commonly used to treat depression. There are drugs from other drug classes that we talk about in this course that could potentially be used for depression, but the 5 that you see listed here are the most commonly used. And there's also complementary and alternative products. There are multiple complementary and alternative products that are thought to possibly treat depression. I'm only going to talk about one, which is St. John's wort. So we're going to talk about all of the drug classes that I have listed here. By and large, the first 3, the SSRIs, the SNRIs, and the atypical antidepressants, by far those are the 3 that you will see most commonly in clinical practice, but we will go through all of these different drug classes. And I have this diagram. This is specific to the SSRIs, which are the selective serotonin reuptake inhibitors. I included this diagram kind of just representative of all the different drug classes, well, specifically the SSRIs, the SNRIs, and the atypical antidepressants, because most of the drugs work in a somewhat similar fashion. Ultimately, the drugs will increase the amount of neurotransmitter at the receptor. They do that via a variety of different mechanisms. As you can see in the picture, on the left side, you've got neurotransmission without an SSRI on board. So serotonin is released from the nerve terminal, and it activates receptors, and then at some point it dissociates from the receptor, and then it is actively taken back up into the nerve terminal. For patients that are taking SSRIs, the SSRI blocks that reuptake step, so that effectively increases the amount of serotonin at the receptor. So some of the other drug classes have a similar mechanism of action. They influence serotonin as well as norepinephrine. That would be the SNRIs. The atypical antidepressants will block the reuptake of dopamine and norepinephrine in varying degrees. And then we'll talk about the tricyclic antidepressants and the MAOIs as well, and kind of how they work. But effectively, in the end of the day, if you look at this this picture, what we're ultimately doing is putting more neurotransmitter at the receptor site, and so that's how these drugs are thought to produce their therapeutic effect. All right, so let's talk about our first class of drugs, the selective serotonin reuptake inhibitors, or SSRIs. The prototype drug is fluoxetine, brand name is Prozac. This drug works by selectively blocking neuronal reuptake of serotonin. So again, that just means that there's going to be more serotonin available at the receptor site. And if you think back to the beginning of the lecture, I said that more serotonin is going to result in improved mood, and then as well as some of those other therapeutic effects that we see when we've got more serotonin at the receptor site. Therapeutic use, so the major use for this drug is major depression. However, it can also be used for bipolar disorder, OCD, which is obsessive compulsive disorder, bulimia, and even premenstrual dysphoric disorder. In terms of adverse effects, there are lots of different adverse effects that occur with this medication. I have to say, for the most part, these medications are well tolerated when you compare them to some of the other drugs used to treat depression. With that said, they do have some side effects that some people just can't tolerate. For example, sexual dysfunction. About 70% of men and women experience some form of sexual dysfunction while they're taking SSRIs. There are things that can be done, such as maybe reducing the dose. The problem with that is you have to balance that with resurgence of depressive symptoms. But it is an option. Maybe switching to a different drug is another option that could be considered. Insomnia is very common. Weight gain also pretty common with the SSRIs, and then there are a couple serious side effects, such as serotonin syndrome and withdrawal syndrome. So serotonin syndrome is related to the increased amount of serotonin at receptors. Generally, it starts anywhere from 2 hours to 72 hours after the first dose is given or after a dose increase. Signs and symptoms: altered mental status, myoclonus, hyperreflexia, sweating, tremor, fever, even death. This can be a very serious problem. And it can actually even be worsened if the patient is on other drugs that increase serotonin levels. That's normally when it's seen. So for example, tricyclic antidepressants, which we'll talk about in a few moments, as well as MAOI inhibitors, they also increase serotonin levels at the receptor site. And so if the patient is on any of those drugs or maybe on another drug that interacts with the SSRIs and increases the levels of the SSRIs, this is when you become very concerned for the patient developing serotonin syndrome. Withdrawal syndrome is also important to be familiar with. So this is really just abrupt discontinuation of these medications. That's when this is seen. The signs and symptoms, typically headache, nausea, dysphoria, among other things. It generally begins within days of the drug being abruptly stopped, and it can last for a couple weeks because these drugs tend to have long half-lives. And so the drug can kind of hang around for a while. And also remember, it takes a few weeks for these effects to kick in, so it kind of makes sense that it would take a little while for some of the for the withdrawal syndrome to be hanging around. So because of that, we always taper the dose off for antidepressants. Finally, I want to mention neonatal effects. NAS, or neonatal abstinence syndrome, as well as PPH, or persistent pulmonary hypertension. These are effects that are seen in babies born to moms who have used SSRIs in the third trimester. So these babies, if the mom is continuing on the medication through the pregnancy, when these babies are born, they have to be monitored very closely for these problems. The other adverse effect that I did not mention was hyponatremia. These medications can cause kind of a SIADH-like picture, and especially in elderly patients, this can be concerning. So these patients should be monitored for hyponatremia. In terms of nursing implications, because this drug causes insomnia, you would want to counsel your patients to take it early in the day, like with their morning meal. Definitely want to provide them with some information about how to avoid adverse effects. And then with all of these drugs, remember I mentioned early on that there's a risk for suicidal ideation. So,
making sure to discuss that risk with the family, making sure that the family members and caregivers are looking out for these signs as well as the patient so that they can be addressed as soon as possible.
So the next drug class are the selective norepinephrine reuptake inhibitors, or SNRIs. These are also very commonly prescribed antidepressant medications. Our prototype is venlafaxine or Effexor. As I already mentioned, this drug selectively blocks neuronal reuptake of serotonin and norepinephrine. Its major use is for depression, major depression. It can also be used for anxiety, panic disorders, and can also be used for pain as well. Specifically with pain, certain types of neuropathic pain are most likely where you would see the SNRIs used. In terms of adverse effects, the adverse effect profile is somewhat similar to the SSRIs with some striking differences. So first and foremost, sexual dysfunction, insomnia. Those are two adverse effects that the SSRIs and the SNRIs are associated with that are somewhat common. Where this drug differs to some extent from the SSRIs are that these drugs can cause hypertension and tachycardia, so they've got cardiovascular effects, which the SSRIs rarely, if ever, cause. Additionally, the SNRIs are more associated with weight loss than weight gain. So that's kind of a major difference between the SSRIs and the SNRIs. Another area where they are similar is that when used with other drugs that influence the amount of serotonin at the nerve terminal, they increase the patient's risk for serotonin syndrome. And I won't talk about serotonin syndrome again. I've already explained that when we talked about the SSRIs, but that's important. And then they can cause CNS depression. So CNS depressants like alcohol could be a problem if taken concurrently with these. So in terms of nursing implications, they're nearly identical with, again, recognizing some of those key differences in terms of monitoring for adverse effects. So monitoring for hypertension or tachycardia, that would kind of stand out as a key difference.
All right, and so the last class we're going to talk about are the atypical antidepressants. The prototype is bupropion or Wellbutrin. It's a pretty well-known drug, commonly used. The mechanism is actually unclear, but it's thought to be related to blockade of either dopamine or inhibition of norepinephrine reuptake into cells. And so in terms of its use, major depression is the main use, but it's also used for prevention of seasonal affective disorder. So it has to be taken early on before that disorder would kick in. And it's also used to treat smoking cessation. Adverse effects. Frankly, the drug is actually pretty well tolerated. Insomnia is one of the problems. The only real serious problem that is associated with Wellbutrin and the atypical antidepressants is that the drug can cause seizures. And so that's definitely something to be familiar with. And in fact, looking down at the drug-drug interactions, this drug is metabolized by CYP2D6. And so any drug that's going to inhibit that can dramatically increase the levels of bupropion, and that's when you really get concerned that the patient could experience seizures. So please know that this drug causes seizures. Please know that inhibitors could increase the levels of this drug. I'm not saying you have to know what those inhibitors are. Just know kind of conceptually that if there's a drug that inhibits Wellbutrin's metabolism, that could lead to seizure activity. Individual variation, so I already mentioned increased risk of seizures in patients with a seizure history, but any patient who's taking this drug, even without a seizure history, could experience seizures while on the medication. The good thing about the atypical antidepressants is that there's a low incidence of weight gain and there's virtually no issues with sexual dysfunction like there are with the SSRIs. And there's also not, this drug really doesn't have sedative properties. It doesn't have anticholinergic side effects. And, it doesn't have those antihistamine-like effects that would cause sedation. So these drugs are, for the most part, well tolerated. Let's move on to the second class, tricyclic antidepressants, also known as TCAs. These have been on the market for a very long time, actually since the 50s. These are kind of like the original antidepressants. They work very well. The problem is they have a lot of risky adverse effects, and we've got much safer drugs nowadays, like the SSRIs. So the use of tricyclic antidepressants has definitely gone down significantly, especially in the last 20 years. However, they are still around. They are still used in some scenarios. They block neuronal uptake of two monoamine transmitters, norepi and serotonin. I already talked about kind of what happens when you see increased levels. Well, first of all, when you decrease or block the reuptake into the cell of norepi and serotonin, that increases the level of those neurotransmitters at the receptor site. And we've already talked about what effects you might see when you've got more norepinephrine and more serotonin at the receptor sites. Therapeutic use, major depression, bipolar disorder is also another potential use. And then some other uses such as fibromyalgia or insomnia. But the main use is depression. Adverse effects. So I mentioned that these drugs will increase the amounts of norepinephrine and serotonin, right, at the receptor sites. But these drugs also have some other actions. They can block muscarinic cholinergic receptors. That means that you could see anticholinergic responses in your patients. They also block histamine receptors, which is what allergy medications do. So they tend to be similar to sedating allergy medications, so they can cause sedation. And then finally, they can block alpha 1 receptors. The alpha 1 receptors, remember, one of the main side effects that we would see when for alpha 1 blockers was orthostatic hypotension. So when you look at the list of adverse effects here, it kind of makes sense that these drugs cause some of these problems because of the blockade that they have at some of these additional receptors. So anticholinergic effects because of blockade of the muscarinic cholinergic receptors. Orthostatic hypotension because of blockade at the alpha 1 receptor. Sedation because of blockade of histamine receptors. That's one of the main side effects that you see, especially with the histamine receptors that can readily cross the blood-brain barrier. And tricyclic antidepressants work in the brain, so of course they can cross the blood-brain barrier. A couple other things I want to mention: arrhythmias and seizures. These can be lethal. You have to know this. These drugs, if they in an overdose situation, can lead to life-threatening arrhythmias and life-threatening seizures that can be lethal. And I have it bolded on the slide: drug interactions. Many drug interactions with these. Just know that there are a lot of drug interactions. I'm not going to ask you to memorize all of them, but I would expect that when you're practicing in a clinical environment, if you come across a patient taking a tricyclic antidepressant, you're going to remember, oh, these drugs have a lot of drug interactions. I need to look this up and make sure my patient doesn't have any interactions that need to be addressed. In terms of RN implications, because these drugs can be sedative, we give them at bedtime. Definitely counsel patients on how to avoid adverse effects. There's anticholinergic effects, how they can be treated. Orthostatic hypotension, meaning they should move from a sitting to standing position slowly, those kind of things. And finally, drug interactions. So I'm not saying that you would counsel your patient on each and every interaction, but what you would do is make sure they understand that they need to let their providers know that they're on a tricyclic antidepressant. That way, if a new drug's prescribed, there can be a discussion around whether there's a drug interaction. Some medication safety concerns, and these are specific to the tricyclic antidepressants. The major issue with these drugs is that they can be lethal in an overdose situation. The lethal dose is only 8 times higher than the therapeutic dose. That means that it's got a pretty small therapeutic window, or we would call this drug a narrow therapeutic index drug. Symptoms that are lethal are usually from the anticholinergic and cardiotoxic actions. And in terms of treatment, it's really just trying to get the drug out of the gut if possible. So gastric lavage, activated charcoal. You could give treatment for dysrhythmias if the patient is experiencing those. And by the way, the term arrhythmia and dysrhythmia mean the same thing. The most appropriate term is dysrhythmia. In practice, you'll hear people say arrhythmia. You'll even hear me say arrhythmia as a parent occasionally, and that's just because that's the word when I was in school. That was the word that was used, and I'm now trying to become accustomed to using the word dysrhythmia. It's just basically disruption in cardiac conduction. All right, so in terms of prevention, this is an important point. Depressed patients, especially like those in the outpatient setting, should not get more than a 1 week supply of tricyclic antidepressants because in many cases they know that if they overdose on this medication that it can kill them. And remember these patients are already prone to suicide to suicidal ideation. Let's move on to the next class, the monoamine oxidase inhibitors, or the MAOIs. These are rarely used as initial treatment. In fact, I'm going to go as far to say they're never used as initial treatment for depression. These drugs have also been around for a really long time, and they're usually like a last line choice for treating depression. Basically, the prototype is phenelzine, brand name is Nardil. The mechanism of action is that they prevent conversion of MAOA, which is one of the types of MAO enzymes. But this is the one that's specific to nerve terminals. And this increases the amount of norepinephrine and serotonin at the receptor site in the brain. These are used mostly, if they are used, they're mostly used for depression, but could also be used to treat bulimia. Adverse effects. So like the TCAs, these drugs can activate receptors such as alpha-1 receptors or cholinergic receptors. So some of the side effects are not surprising, like orthostatic hypotension. Again, not surprising. CNS stimulation is a side effect that you would see. These drugs act centrally and they can cause CNS stimulation. But the one you guys absolutely have to know, without a doubt, you have to know this, is that these drugs can result in hypertensive crisis. So while the drug itself can cause hypotension, in the case of patients who are eating high tyramine containing foods, that can actually precipitate a hypertensive crisis. And really what the reason why is because that MAO enzyme is what it is actually an enzyme that's in the gut. It's also in the liver. And if when this enzyme is inhibited, that it actually promotes the release of norepinephrine and from sympathetic nerves, and this has to do with the tyramine breakdown. So this enzyme normally breaks down tyramine in foods, but when this enzyme is inhibited, then the tyramine kind of is floating around freely, and that promotes norepinephrine release from sympathetic neurons. And this can literally cause patients to go into a hypertensive crisis, which is life-threatening. So making sure patients don't eat high tyramine containing foods or other risky foods while they're on MAOIs is extremely important. If this inhibition does last for quite some time, so it's not like they can stop taking their dose for a couple days, eat the food, and then restart it. This inhibition will last for a couple weeks. So the patient really needs to understand what the risks are with these particular foods. You should give the patient a list of these foods when you're counseling them. And you should also tell them that there are a lot of drug-drug interactions as well that result in the same problem. So if the patient is on other drugs that will inhibit MAOI or increase norepinephrine levels, then these drug interactions can be serious and can lead to hypertensive urgency. Hypertensive crisis.
So this is a diagram from your book that further explains the interaction between dietary tyramine and the MAOI inhibitors. You don't have to memorize the details I'm about to provide, but I know some of you do better remembering specific facts about drugs when you understand kind of why they happen. So I'm going to go through kind of the detail here and why patients who take MAOI inhibitors are at risk for hypertensive crisis when they consume tyramine containing foods. So on the left side of the screen, you see what kind of occurs in the absence of patients taking MAOIs, or let me say that differently. On the left-hand side, you have a patient under a normal scenario who is not taking an MAOI inhibitor. So essentially, tyramine that's ingested in the diet is inactivated in the liver as well as in the gut by MAO, which is the enzyme that deactivates tyramine. So any dietary tyramine that's not metabolized in the intestinal wall goes directly to the liver and then it's inactivated. So no tyramine actually gets to the systemic circulation under normal circumstances. Now, on the right-hand side of the screen, this is a patient who's taking an MAOI inhibitor. And what will happen if that patient consumes foods that are high in tyramine content? So first things first, the drugs are going to inhibit MAO. So you can see that up at the top left-hand side of the diagram. MAO has a big red cross over it, and so inhibition of neuronal MAO raises the levels of norepinephrine in the sympathetic nerve terminals because that inhibition is preventing the release of norepinephrine, right? So norepinephrine is going to start to accumulate in the nerve terminal. And then look down to the liver. When that MAO is blocked in the intestine and the liver, tyramine will escape from the portal circulation and get into the systemic circulation. And that tyramine is going to travel, upon reaching the sympathetic nerve terminals, it's going to get into the systemic circulation and travel to other parts of the body, and it's going to promote the release of accumulated norepinephrine stores. And this is what causes massive vasoconstriction and excessive stimulation by the heart, essentially the symptoms of hypertensive crisis.
The last drug I'm going to talk about is actually not prescription. It is a complementary and alternative medication. It's called St. John's wort. You guys may have heard of it. The thing about St. John's wort is there have been studies looking at its effectiveness, and it was found to be no more effective than placebo for treatment of major depressive disorder. But it does decrease symptoms, but it does so to the same extent as placebo. Nevertheless, it is sometimes used to treat mild to moderate major depression. Would not be used for severe depression. There's just absolutely no evidence to say that it would be effective. So in terms of adverse effects, they're pretty mild. One issue is photosensitization. So if patients are on St. John's wort and they're in the sun, they should put on sunblock. And then this could cause a precipitation of serotonin syndrome with other antidepressants, such as SSRIs. So that's something to keep in mind. It is a potent inducer of the CYP P450 system. So St. John's wort can cause serious drug-drug interactions. It also induces the P-glycoprotein, which is just a protein in the body that transports drugs in and out of different parts of the body. But I'm not worried about you knowing that. I think the most important thing for you guys to know is that it's a P450 enzyme inducer, so it can cause some serious drug interactions. Finally, one of the issues that's across the board with all of your complementary medications is that there is to some degree of lack of standardization with these products. The quality can be an issue. Unless the quality is certified by an organization like the USP, I wouldn't recommend that a patient use it. So I would always recommend that they look on the label to say that the quality is certified. And that means that what's in the bottle is actually what it should be, because some outside organization has affirmed that. All right, so let me just go over a couple nursing implications. Frankly, you guys can read through these. These are on page 360 in your book. I just want to really focus in on the second and third bullet point just for a moment, just to kind of drive home some of the key points with these drugs. The risk of suicide is a real risk. Remember, depression patients already have an increased risk of suicide, but when they're on medications, that risk is still there. And the risk is greatest. It can actually even be increased, especially early on in therapy. The risk is greatest among children and young adults. So the family really needs to be advised to monitor for symptoms of decline in function, and that needs to be reported immediately so that the patient can be evaluated and so that help can be provided if needed. Um, Patients generally are followed up pretty close at the start of therapy. The other important thing I want to just kind of bring to your attention once more is promoting adherence. You really do need to educate patients that these drugs take time to work. It's not going to start working in a couple days or in a week. It's going to take probably a good month to see the real effects of the drug. They develop over several weeks. Sometimes in some patients it takes a month or two. They've got to be taken as prescribed even when the patient's feeling good. And usually they're going to be on the medication for, maybe even as long as 9 months or even longer after their symptoms resolved. Please read about the other nursing implications. These are less related to the actual drug therapy, and I think that when you guys read through them, they're pretty straightforward. And from a nurse perspective, you guys will think they make total sense. All right, and that's it for our discussion of antidepressants. If you have questions, please post them to the discussion board. And thank you for listening.
So a patient with depression has been prescribed fluoxetine. Which statement made by the patient indicates an understanding of the medication teaching? Please review all the options, maybe pause the tape and think through them, and then restart the tape and we will talk about the correct answer. So hopefully you thought through those options, and if you came up with C, then you are correct. It may take a few weeks before my mood is elevated. Remember, we talked about all of the antidepressants and the fact that the initial responses will take some time to develop, anywhere from 1 to 3 weeks to see some improvement. Max response can take even longer than that, up to a couple months. So C is the correct answer. The medication should not be stopped when the patient's feeling less depressed. Generally, once the patient's symptoms have completely subsided, the medication will be continued thereafter for several months, and that's to reduce the risk of relapse. The drug may enhance my interest in sex. That is also not true. We talked about the fact that one of the biggest problems with these medications is that they cause sexual dysfunction. And then disorientation and hallucinations are common. This is also not true. However, if the medication is abruptly stopped, and so if the patient's not following the prescribing instructions or they run out and they don't have access to refill their medication, in that scenario, they might experience some of those effects because those are the effects that are associated with the withdrawal syndrome. However, if they're taking the medication as prescribed, they should not experience those side effects. All right, and question number 2. A patient with depression has been prescribed venlafaxine. Which of the following adverse effects would you discuss with the patient during discharge teaching? So again, please read through the options, maybe pause the tape for a moment and think about it, and then we'll go through and talk about the right answer. Okay, so hopefully you all came up with C, increased blood pressure. So remember I said cardiovascular issues like hypertension or tachycardia have been associated with venlafaxine. So warning patients to monitor their blood pressure. They can do that at the grocery store. They can do it at the pharmacy usually, is wise instruction. This drug does not cause drowsiness. It actually causes insomnia, so it would be unlikely to see drowsiness with this medication. This medication class does not increase the risk for seizures. The atypical antidepressants like Wellbutrin increase seizure risk, and then these drugs do not generally impact electrolytes. Okay, and the last activity I have is an active learning scenario. I'm not going to go through this learning scenario with you, but I hope that you will take some time and work through this. So in this scenario, you have a patient who is in the emergency room. They're being treated for hypertensive crisis. And the patient reports taking phenelzine or Nardil, which is an MAOI inhibitor, and that the patient had pepperoni pizza earlier that day for lunch. So think about kind of the consequences of a patient on an MAOI inhibitor eating pepperoni. It makes sense that the patient may be experiencing hypertensive crisis, but kind of talk, what I would like you to do is think through why that occurs. So, why does hypertensive crisis occur in patients on MAOI inhibitors that eat certain types of food? What are the expected findings of hypertensive crisis? Now, I didn't teach this necessarily as part of the lecture, although we did discuss some of the findings. So please think through those. What medications are used to treat hypertensive crisis? So for this, you'll have to think back to your hypertensive lecture. And then specifically for a patient on an MAOI, what patient education should occur to prevent hypertensive crisis in the future? So that would be as it relates to foods as well as any other education that you would want to give your patient to help them avoid hypertensive crisis because it can be life-threatening. I'll post a summary with the answers, but definitely try to do this active learning scenario. This is kind of where the rubber meets the road.